Okay, so let's go ahead and get started. Good afternoon, everyone, and good morning to those joining us from the West Coast. My name is Hamera Osman, and on behalf of Muscular Dystrophy Canada, I am very happy to welcome you to our webinar from our new Let's Talk NMD, Let's Talk Neuromuscular Disorders series. Before I introduce today's topic, as always, I would like to mention that all participants have been muted, but I welcome you to type any questions or comments throughout today's session in the chat box. We have also allotted time at the end of today's webinar for a live Q&A. Please note a recording of today's webinar will be available by the end of the week on our MDC YouTube channel. With that said, let's get started. Today's weekly webinar is on speech, swallowing, and communication. This is a very timely webinar as May is Speech and Hearing Month here in Canada. This month is dedicated to raising awareness on communication health. People with neuromuscular disorders are often supported by speech-language pathologists, SLPs, and by specialized technology for their speech and communication needs. Some of these supports have been discontinued due to COVID-19, while others have been moved online. For children and adults with neuromuscular disorders like SMA, spinal muscular atrophy, Duchenne muscular dystrophy, OPMD, myasthenia gravis, FSHD, speech-language pathologists can provide a vital service helping with speech, chewing, swallowing, and using technology and other equipment to improve quality of life. We are very grateful for our terrific lineup of speakers that can help to address questions and concerns you have about speech, swallowing, and communication for individuals with neuromuscular disorders. In advance of their presentations, I would like to thank each speaker for their time and expertise. First, we have KIERA BERGGREN, who is a research speech-language pathologist in the Department of Neurology at Virginia Commonwealth University. Prior to working as an SLP, she had trained as a chemist and worked as a research technician in several different labs. She started her second career as an SLP in rehabilitation following acquired neurological injuries such as stroke and traumatic brain injury. She quickly discovered a passion for working with individuals with neurodegenerative diseases and currently provides swallow, communication, and cognitive support to patients and families in multidisciplinary clinics for ALS and the MDA. Marrying her current career and her research background has allowed her to also be active in research in several neuromuscular diseases, including myotonic dystrophy, FSHD, ALS, and others, where she has been looking at orofacial strength, swallow function, and changes in speech. Welcome, KIERA. I will go ahead and stop sharing my screen so you can share your slides.
All right. Is this showing up okay?
Looks great. Go ahead.
Great. So I am down in the States. I work at Virginia Commonwealth University. I've spent the last 6 years working with neuromuscular diseases and ALS, and we cover a lot of ground as speech therapists. I'll try and cover everything, but be brief about it to leave time for everybody else and certainly for questions that I see are already popping through. There we go. Couple of disclosures for the FSH Society, for Biogen, otherwise nothing else relevant. We're going to talk a little bit about neuromuscular disease and swallow and speech, and then how can a speech-language pathologist help with this, swallow in particular. I always like to start off with this slide of what is a speech-language pathologist. Down in the States, we don't have that hyphen in there. We just say SLP, but we may be called speech therapists. Usually when I walk into a patient's room, though, they might tell me, you know, I talk just fine. Why am I seeing a speech-language pathologist? And so I like to say, you know, we cover voice, speech for sure, how we make those sounds when we communicate, language, reading, writing, listening, talking, the pragmatics, facial expression, body language, all of that. Hearing, we are not audiologists, but that I think of it as our kind of our sister profession. And so, and it's very important in communication to know what hearing function is. So we look at that as well. Cognition, of course, attention, memory, being able to, you know, tell a story, inhibit behaviors, all of those kind of things fall under cognition. And then swallowing is another big piece of our practice. And we look at swallowing kind of from the first moment it enters the lips all the way to the very end. So, and a couple quick definitions that you'll probably hear throughout the talk today, my talk, and certainly the later conversations. Dysphagia just means swallowing difficulty, and dysarthria can be, there's multiple different kinds of dysarthria. The ones that I see most commonly with neuromuscular diseases are flaccid dysarthria or spastic dysarthria. And it just depends on which neurons are kind of involved and how they're involved. So just so you know, dysphagia and dysarthria. So this is a slide, this is not meant to be comprehensive by any stretch, but really just kind of an example of, if we think of all the different areas that speech language pathologists can help out with, and then we think of kind of some exemplary neuromuscular diseases that, you know, where are some crossovers there? So like congenital myotonic dystrophy, you know, may have issues with all of these areas. CMT, I know we already had an early question about Charcot-Marie-Tooth and hearing. In the literature, there is certainly documented changes in hearing. It is not something I have seen as commonly in my practice, but I do see it every once in a while in my CMT patients. Myotonic dystrophy, again, kind of a smattering across the board. Duchenne muscular dystrophy, FSHD, inclusion body myositis, limb girdle, myasthenia gravis, Pompe, and SMA. And with all of these, there's some heterogeneity in each of the diseases. No individual is necessarily going to have all of these or have none of these. And sometimes in the case of like myasthenia gravis, dysphagia might be the only symptom that somebody has, or an early dysarthria that is not explained with any other disease process. And so we then we treat that dysarthria, and we look at how to support that piece. So again, this is not exhaustive by any stretch, but just an example. Really briefly, I'm going to focus a little bit more on the swallow, but briefly, when I go in to see a patient, I'm thinking about what is normal swallow like. So I'm hoping you can see my mouse on the screen. Maybe not. Basically, think about it as, you know, when food first gets into the mouth and we kind of manipulate it around in our oral cavity with our tongue, with our jaw kind of chewing and moving things side to side, chewing things up, or holding liquid in our mouth with our tongue, keeping it in position. And then the act of swallowing itself, where our tongue kind of expands, fills our whole mouth up and pushes food back into our throat or our pharynx, and then down into our esophagus. I should let you know that at rest, you and I and everybody that's listening to this webinar right now, unless you're actively eating, your airway is the tube that is open. So that you're breathing in and out. But when we go to swallow, we want to have food go down the right tube and not the wrong tube. And so then our esophagus, which in this picture, it's hard to show everything in one static picture, but the top end of our esophagus near, just above where it says the word esophagus, is our upper esophageal sphincter, and that is actually closed at rest, so we don't get air into our tummy. But when we go to swallow, our airway closes and our esophagus opens, so food goes down the right tube. It's a pretty complicated process that we engage in. There's a lot of muscles that are involved. It does require that we hold our breath when we're swallowing, so we don't get food down into our airway or liquid into our airway. And it's pretty intricately timed. So you can see there's a kind of a lot going on with this. There are 4 sort of phases of swallowing that I've kind of listed here that I'm thinking about when I see somebody that maybe has some concerns with swallowing. I wanted to share a little bit, again, sort of a smattering across the literature of rates of dysphagia. So depending on diagnoses, it may be as little as none at all for many neuromuscular diseases to up to 100% in something like OPMD or type 1 SMA, where it's the swallowing musculature is very involved in those 2 diseases. The same muscles that we use for swallowing, we use for speech as well. So if we have weakness in our tongue, our lips, our cheek, any of those areas, this can affect both our swallow and our speech, giving us both dysphagia and dysarthria. They don't necessarily coincide, but they often are sort of seen together fairly commonly with neuromuscular diseases. And obviously, if we have some weakness in those muscles, then they're not going to move as much as we would like, maybe not generate as much pressure to help squeeze food down into our esophagus. There may be, for certain neuromuscular diseases, postural changes. I'm thinking specifically like Duchenne muscular dystrophy. There may be some respiratory weakness, which can contribute to dysphagia and be concerning, when can also affect speech. We don't have enough sort of power to get loud enough and have enough volume when we're communicating verbally. Very rare, but especially in myotonic dystrophy, myotonia is obviously can be present, can affect speech and swallow. You can have myotonia in the jaw, the tongue, the upper esophageal sphincter, down in the esophagus as well. And then ataxia, which is not as common across the neuromuscular diseases, but we do see it from time to time, and that's kind of a muscular incoordination. So in the interest of time, I may be a little bit brief in some of these, but sort of I wanted to kind of briefly look at some common symptoms of dysphagia. These slides certainly will be available later as well for you to look at. My email is also at the end if anybody needs to contact me with more questions. But when I'm looking at the oral phase of the swallow, can people get food into their mouth? Can they move it around? Does it come out the front? Are they able to chew it well enough? Can they start the oral phase of swallow? Do they have food left in their mouth? A common complaint I hear is not so much in the oral phase, but in the pharyngeal phase, the sort of back of the throat area, and the esophageal phase is that feeling of food stuck in the throat, or I feel like I'm coughing or choking, or my voice sounds kind of wet or gurgly. These are all sort of signs that I am listening for when I talk with a patient about how is eating going for them, and it kind of perks my ears up and makes me look a little more closely. In infants, similar symptoms, although they have some slightly different ones just because of the nature of how they eat. So maybe they might be falling asleep at the beginning of a feeding, or they might have kind of a hard sounding swallow. I don't hear that as commonly in adults, but I do see it in young ones. They may refuse their bottle actually, because they may decide that, you know, their system is telling them it doesn't feel very safe when they're eating. So they may just kind of turn away from the bottle, and it can take them a very long time to eat small amounts. I didn't highlight it on the previous slides, but average meal time for adults at least is about 20 minutes. If we have a neuromuscular disease, on top of that, that can actually prolong those eating times. And so if meals are taking 45 minutes, an hour, or something like that, it also perks up my ears and makes me worry about fatiguing during a meal and if there's any concerns with that. If somebody has dysphagia, there's different types of swallow assessments. We can do a clinical swallow where I'm in my clinic room with you, or an SLP is, and I'm feeding you foods and liquids of different consistencies, and we just see what happens and how you normally eat. We can also do one in radiology called a modified barium swallow study, or in other parts of the continent, it has different names. I threw a couple other ones on there. Where we have somebody eating food or liquid that has barium in it, so we can see it on x-ray, and we make this x-ray video and watch basically where things are going and where there might be areas of concern. We could also do a FEES, a fiber optic endoscopic evaluation of swallow, where we basically put a camera in kind of up through your nose and down through into your throat, and sort of watch as you eat as well and see how things are going. I really like to stress with everybody though that no one fails a swallow test. As speech language pathologists, we're therapists, and that's our job, is to sort of look and see, okay, yep, there might be a problem, but how do we address it? How do we manage it? So maybe it's changes in diet, maybe supporting somebody in a different posture, or strategies when they're eating. The literature right now in neuromuscular disease is not very broad in terms of using therapeutic exercises. I know there was an early question about exercise in the stroke population. Some of those are starting to be explored in the neuromuscular population. I would encourage you to talk individually with a speech language pathologist about whether it might be appropriate for you or not at this, depending on what your concern is. Oral hygiene, are we brushing our teeth clean enough or well enough so we're not getting bacteria going down the wrong tube? Are we fatiguing during a meal, and how can we kind of modify that? And I always like to talk quality of life. What's our goal with eating? I work both in neuromuscular patients clinics as well as in ALS, and so that's a common conversation we have with the ALS population as well. So some tips to kind of help somebody with dysphagia at home, and there's quite a few on here, from, you know, sort of making sure you're upright, not, you know, mom was right, don't talk with food in your mouth, taking smaller bites and sips, not gulping, maybe controlling how quickly somebody's eating if you're helping somebody eat. I have had some patients where we just limit portion size, so that kind of slows them down a little bit. But these are very individual, and, you know, not somebody, if somebody is listening and has dysphagia and has concerns, I wouldn't say try all of these, but maybe work on a couple of these and see if that helps, depending on what your particular concern is. The big one down near the bottom is looking at limiting fatigue at mealtime. So maybe instead of having 3 larger meals during the day, maybe having 4, 5, 6 smaller meals. Or it's your birthday and you want to have steak and a taco salad, which are complex foods, maybe having them earlier in the day when you have a little more energy and not quite as fatigued. So I might recommend changing consistencies. I mentioned that at the beginning of the last one. I wanted to include this link here, which is kind of a sort of a review of several different dysphagia cookbooks that are out there. But in general, if you have softer, more moist foods, these can be easier to ingest. Thicker liquids might be a little bit easier to control in the mouth. In the rehab world, that was commonly where we would start with somebody with dysphagia. We'd start thicker liquids, progress to thinner liquids. But I'm finding in neuromuscular diseases that it can be very individual, and some absolutely hate the thicker liquid. So there's no one size fits all by any stretch. I do like to always mention as well alternative nutrition. It's not common in most of the neuromuscular diseases that I see. Certainly with ALS it may be, but there's different types. There's nasal tubes that go up through the nose and down into the tummy. And those are usually only temporary, as opposed to a gastric tube, which is a surgery and is a little bit more permanent. And I like to tell patients that these are never meant to be an either or proposition, especially with the adults that I work with. You know, we have this discussion of risk, relative risk, and what are our goals around feeding. And so for some people, they may be, you get all their nutrition through the feeding tube, and others do a mix, or there's a day that they want to have, you know, a piece of chocolate cake, and I would say, let's go for it, but here, let's try and be cautious about how we do that and be as safe as possible, but maybe get the rest of the nutrition through that feeding tube. So there's a bunch of adaptations that are out there. I will often work pretty closely with occupational therapy to look at what might work best for a given individual, whether that's, you know, a larger handled utensil and a bumper on a plate, like the plate on the far right with the fruit on it, or the blue bowl, plate/bowl with the bumper on it that's built in, so you can kind of scoop up against that, or a cup that's a little bit easier to drink from, or a straw that maybe helps kind of slow people down. With our little ones, our babies, there are several different manufacturers out there of bottles that have different nipples that can go on to help regulate flow for thicker or thinner liquids as well. So lots of options out there. I think in the setting of COVID-19, the biggest question I'm getting right now is the telehealth side of things. And I am actually in my clinic today, and I'm seeing almost all of my patients virtually today. And what's nice is at home, I can see what are they actually doing? You know, when they're eating, are their elbows propped on the table? how easy is it for them to get food or during the day, or do we need to have a little cooler next to them that can be close by and they can get their calories? You know, are they sitting at the table? Are they using a tray? The communication piece is a big one as well too. You know, how are they managing that, and what do they have available to use? Who do they commonly chat with? And as SLPs, I know we have other speakers talking about it as well, that communication side of things. You know, we never look at it as a one size fits all, but sort of how can we kind of best support communication for everybody in these situations. So I know that was a quick overview. Feel free to contact me, references with all of this, and then my email, and then you can also email the Muscular Dystrophy of Canada as well too. Thank you.
Excellent, thank you very much. I'm just going to move on to Dr. Laura Ball's side here. Here we go. So Dr. Laura Ball recently moved to Mississippi University for Women after being the Director of Hearing and Speech Research at Children's National Medical Center in Washington, D.C. She completed her PhD at the University of Nebraska-Lincoln and has over 30 years experience as an SLP. She has research and clinical interest in complex neuromotor disorders across the lifespan. She has publications involving functional communication, augmentative and alternative communication, AAC, and neurodegenerative impairments, including ALS, spinal muscular atrophy, childhood apraxia of speech, neuroimmune disorders, and white matter disease. Dr. Ball?
Thank you. Let me see if I can get my screen. Oh, are you going to do mine or my? Okay.
You can go ahead and share your screen. I've gone ahead.
Sorry, I'm going to get there shortly.
Looks great. Go ahead.
Okay, there we go. So yes, I'm going to be talking about augmentative and alternative communication. There are a few things that basically I just kind of wanted to talk first about what is augmentative AAC. Augmentative and alternative communication. And basically it includes strategies, methods, and technologies that we use to support communication. It's also considered a form of assistive technology in that it reduces barriers for an individual to communicate. There are different types of AAC. Some involve no technology at all, and they include things like communication books, communication boards, and even remnant books that help people communicate. Especially, I think they're very helpful for communicating across different environments. There are low technology speech generating devices. In the States, I know we refer more commonly now, I think, to them as speech generating devices than AAC devices. So I kind of have those alternating here. But some of the low technology examples would be things like talking photo albums, GoTalk devices, which is the green system there on the right that I have an image of. And that one has 9 possible communication messages, and there are different devices that range from, I think, 1 basically through probably 60 some, 84 perhaps. And then there are also some that just are 1 message devices. Most of what I'm going to be talking about, however, is probably going to involve more high technology AAC, and those are primarily computer-based systems. And there are a few companies that are really notable for that. One is called Tobii Dynavox, one is called Prentke Romich Company, PRC, and then there are a lot of apps that are available now on for use on an iPad. So that's kind of a very quick summary of what is AAC. And I wanted to talk to you a little bit about some of the literature that's available. As she just mentioned in the previous talk, there is kind of a limited amount of literature available for people with progressive neuromuscular disease. But there are a few things that we know, and one in particular is that using AAC is considered standard of practice for intervention for communication impairments with people with progressive neuromuscular disease. And we know too that people with progressive neuromuscular disease can maintain effective functional communication, and you can implement AAC whenever natural speech does not meet all communication needs. And I want to emphasize that because I think there's a misconception that it's still among several people or many people that people get AAC only if they're not able to talk at all. And really the idea of this is you can certainly use it as the primary means of communication, but you can also use it as a way of supporting when you have communication breakdowns. If there are certain situations where communication, you have a very difficult time or more challenges being understood. And some of the different neuromuscular diseases have different reasons and different needs for AAC. AAC is customized to accommodate individual needs and abilities. So I have a few examples here with Duchenne muscular dystrophy. Often people have decreased respiratory support, and as a result, they have reduced intelligibility or understandability of their speech. And, so they may have difficulty getting loud enough to call for help, to interact loudly enough in the classroom, at work, over noise, things like that. With myotonic muscular dystrophy, people have slow relaxation of muscles. There's a higher incidence of autism spectrum or social communication impairments, learning impairments. All of these symptoms may impair access to AAC, and that's especially the case with direct access. So there's some techniques that we use in AAC to make sure that people are able to directly access messages as much as possible. For spinal muscular atrophy, respiratory overall weakness, we tend to take more advantage of the strength that is preserved distally. So oftentimes too, if we're working with children, we have to start with more transparent symbols because they're not able to read. But then we focus on language development and then move very quickly into literacy to help them with their overall interactions. As far as AAC technologies for people with progressive neuromuscular disease, like I said, we tend to go more toward the higher technology types of systems. And I've got a few slides in a minute I'll show you that have some examples of that. Some of the ways that we recommend people access AAC technology is through eye gaze tracking. It's probably now the most common method for direct access. And essentially what happens is the computer is set up to track the movement of eyes using infrared technology. And so where you look actually becomes the cursor. And if you dwell on a spot on the screen, it will activate it and speak. Head movement technology or head movement tracking is another method that's similar, except that instead of tracking eye movements, it's tracking the movement of a reflective surface. And typically what people do is they'll place a reflective dot either on their glasses or on their forehead. It kind of looks like they're wearing a bindi. And that tracks the movement of their head. And so then their head movements assume cursor control and work in the same way. Gesture tracking is a new system that is being developed that basically takes head or hand movements and translate those into a method of accessing the system. And it's been developed and research has been shown to that these movements can translate into faster and more accurate message creation. You can find more information on that at Invotech, which is a small company that's a research-based company, basically. Then there's speech recognition and brain-computer interfaces. Speech recognition is an option for some, although I would say that often what we find is that people with dysarthria, with any kind of impairment of their speech, often have difficulty with the speech recognition systems accurately recognizing their productions, and so that is something to keep in mind. The brain-computer interfaces are new and emerging technologies. I have an image of one example here on this at the top of this slide, and you can see that this individual is wearing this cap that takes their brain, the electrical impulses from their brain waves, and is able to translate those waves into cursor control. This is one example. There are some now that are even involving surgical procedures where they're implanting these electrodes into the motor areas of the brain, and people are actually able to communicate in the same way, basically by moving the cursor around on a keyboard. And I thought I would share with you a study that I recently did with a group of people at Children's Hospital in Washington, D.C. This was just a family survey. We had 35 different families that were representing 35 different individuals with spinal muscular atrophy. We did this project in collaboration with the International SMA Patient Registry. And just to summarize a few of the findings that we had, the families reported that the person with spinal muscular atrophy exhibited severely impaired functional communication, in that their clarity, their independence, their intelligibility of their speech was severely impaired. They also reported very clear evidence that AAC improves their communication. They confirmed what we generally know, that individuals with SMA exhibit little to no receptive language or cognitive impairments. However, they said that assessments that are done typically will highlight poor skills, and the reason is because they do not reflect the individual's true abilities because of their impaired communication skills. And they also reported multiple barriers to obtaining and implementing AAC, and they were barriers that we commonly encounter, unfortunately. Funding is one, delayed referral, lack of system trials, difficulty with transportation, and that kind of ties in both to transportation to medical centers, but also having access to the systems. And then limited device or access availability. The figure on the right is one of the figures that we created as a result of this. And what we found was that 57% of all of the participants had no AAC use at all. And of the 43% who did use AAC, they used it for, they used speech, but they also used gestures and the communication system. A few of them only used a communication system, and then some of them used gestures as well. And so it just kind of shows the distribution of how they're using their communication. Overall, the participants reported that AAC enhances the quality of life. And what they reported was that in the context of quality of life, what they reported was that the communication enhances the person's ability to achieve, to express emotions, to expand independence, to express needs, to be understood, to advance personal relationships and improve relaxation and recreational activities, broaden school interactions, and to build a support system. And so I think that it's something that I'm sure people who have neuromuscular disease in general, certainly SMA, probably are all aware of. And a lot of these things were things that clinicians are aware of, but we do now have some confirmation of this. And so next I thought I would just kind of quickly run through a few examples of augmentative communication systems to kind of show you some of the various options that are available. And this is by no means comprehensive. So these are AAC or speech generating devices. The upper row is primarily systems that are accessed using a touch screen. And then the ones here below show eye gaze, and you can see that basically it's the same type of touch screen, but then there's a camera positioned at the base so that the person can use eye gaze. This is another example of a man with SMA actually, who has an eye gaze system placed there at the base of his system. And these are some other options. I talked about the head mouse or the head tracking. And this is something that is placed at the top on a laptop at the top of the screen. You can also use these and position them on the top of other screens as well. And then these are other access options that you can use for scanning, which is something that I didn't go into much detail on, mainly because more and more people are using the direct access methods because they do make communication faster. This is a company that's called Prentke Romich Company, and they just recently merged with Saltillo. And these are two of their systems, and you can see they have very different symbol sets, and they're used to be actually their intent is actually to speed up motor programming so that they can communicate more rapidly. And you can see this particular one on the left, the Prio, is actually it's an iPad system. And the one on the right, the Accent, also can be paired. It's also a touch screen, but you can also pair it with a device that they call the Look Eye, which is an eye gaze access method. This is another company that's called Tobii Dynavox, and they have a variety of systems as well. All three of the systems here, the I-Series system, the Indy, and the I-110, all are touchscreen systems. The ones on the left, though, are also designed with embedded eye gaze access. The Indy is also another iPad system. These systems allow a variety of different ways, screens or displays. So you can see here they have symbol sets, but you can also have standard keyboards, and you can have a mixture of both. And the rest of the slides that I have actually, I think, are primarily iPad apps that are available. And again, I'm just touching the surface. This is the Touch Chat, which is an AAC system with word power. And this is what I was saying, just to kind of show you one way that the different systems can change display. So you have a keyboard, you have a mixture of some symbols, you can group them by categories, and the kind of light purple boxes there, actually, as you're typing, will predict. So in the same way that now we have, when we're texting, it will predict the word. You can also do that in these systems so that it will speed your rate of communication. This is another one that's called Verbally. And then this one, it's primarily for people who are literate, as you can see, because the words are spelled at the top. So that will enable you to use more frequently used core words without having to spell them and put a space, but you also have the keyboard and you have word prediction. Here are a few other iPad apps. These are from a company called AssistiveWare. and they have one that's called ProLoquo to go, and then they also have one that's called ProLoquo for text. And so again, you can see that for someone who is early in literacy development, perhaps you get the symbols, but it also pairs the text with it. And then for someone who's fully literate on the right, you can see it's primarily text-based interaction. And then finally, a couple of others. This is the one on the left is a system called GUS, which is available. That's actually a company. And so you can get different apps from them as well. And they also have different communication devices. And then Word Power, I think we mentioned earlier in the, when I was talking about PRC, I think it's available there. But you can see again that this is primarily for someone who's literate. Thank you very much.
Thank you very much. That's great. Thank you, Dr. Ball. Next, we have Tracy. I'm just going to move to your slides. Sorry, Tracy, just give me one moment here. And I'll unmute you as well. There we go. So next we have TRACEY LAGERQUIST. TRACEY graduated with a master's in speech language pathology from the University of Alberta in 2005. She has over 15 years experience working with pediatric populations in both the healthcare and school systems. TRACEY provided speech and language assessments, consultations, and treatments for school-aged and preschool populations through Alberta Health Services for the first 13 years of her career. In October 2018, she took a position with Edmonton Catholic Schools, providing support for children diagnosed with severe developmental delays or disabilities in preschool and kindergarten classrooms. TRACEY is married and has 2 sons. Her oldest son has been diagnosed with spinal muscular atrophy type 3. Welcome, TRACEY.
Thanks for having me. So the previous speakers have done such an amazing job that I think I'm going to kind of jump ahead to, why don't we jump ahead to slide 5? Right there, that's perfect. So just moving back 1 slide. Thank you so much. So working in preschools and kindergarten classrooms, there's lots of kiddos who have multiple difficulties in many of the areas that were previously mentioned. One of the biggest things that parents and teachers talk to me about is speech clarity. So the impact that speech difficulties have on the kiddos' clarity and the ability of adults and other peers to understand them. So what I wanted to do is just go through some general strategies that may be helpful for teachers to use in the classroom or for parents to use with their own kiddos. And I'm mostly going to speak more so to the pediatric population, as those are the kiddos that I serve. So really some ideas for just tips for the speaker. Slowing down your rate of speech makes a huge difference. So giving yourself time to get all of your articulators in the right spot will make a big difference. As well as trying to increase your volume. So if you're able to speak louder, try that as well. That will have a big impact on your clarity. As well as focusing on key or important words. So try to focus on the key 1 or 2 key words that will support the context so that people are able to better understand your messages. As well as saying so in the same line, saying 1 or 2 words at the same time will really increase clarity. If you have that consistent breakdown and the listener isn't able to understand, kind of supplementing what you're saying with gestures or drawing or writing if you're able, or for those people who do use either low-tech or high-tech AAC, especially with kiddos, sometimes they need reminders to You know, sometimes, especially in the classroom, the kiddos forget to bring it with them, you know, wherever they're going to gym or going out for recess. So sometimes these kiddos need reminders. Let's use, I know one of my kiddos that I'm supporting with AAC says my talking iPad. So I give them gentle reminders to help with clarity. So as was previously mentioned, this kiddo doesn't need words to use. He needs support with clarity and speech clarity breakdown. So we just use a gentle reminder to help me with your talking iPad to help me get this message across. Next slide, please. And I also wanted to provide some tips for the listeners, especially if you're the adult and you're having a hard time understanding your child. First of all, really the environment. Being in a place that's going to be quiet will make a huge difference, so you don't have that distraction in the background. Of course, being face-to-face, I mean, that's just part of being a good listener in general, but being able to watch that person's face and lips will also help clarity for sure. And really being honest when you don't understand. I know I see, you know, teachers and parents just sometimes you nod because you don't understand and you try and move along with the conversation, but we really want to know. We want to be honest when we don't understand what somebody says because it's important. So maybe try repeating the words that you didn't understand, or sorry, repeat the words that you did understand so they know which words they need to clarify and try again. If they don't need to repeat the whole sentence, that kind of takes the load off. And then if you're still not understanding, try asking some guiding questions, either in a yes/no format or with choice questions. You know, did you mean to say sandwich, yes or no? Did you say sandwich or macaroni? Just presenting it that way to help clarify their message. And again, maybe providing some reminders to, can you point? Can you give me a gesture? Can you write it? Or again, cueing, can you show me on your AAC system? Can you show me on your talking iPad what you're trying to tell me? Just to make sure, like I said, we want everyone to know that their message is important. And this is something that often comes up. You know, being able to be understood in the classroom with peers and adults is really important. And, you know, as parents, I think at home, we're better able to interpret messages because we're in that familiar environment, but it certainly breaks down more at school. Next slide, please. So I really just want to go into, I know we're running a little bit short on time. I wanted to talk a little bit about just kind of the experiences I've had still supporting clients. So even those, you know, parents are coming forward, you know, we still have these concerns where, you know, we still want to keep working on what we were working on within the classroom and what we were working on before at home. We don't want to lose those gains. And certainly that doesn't have to be the case. You know, especially within Edmonton Catholic Schools, we worked really hard to get moving, you know, right away. The second that we heard that schools weren't going to be, or schools were going to be closed, we wanted to be able to still support the kids that, that needed our help. So certainly SLP support is still available. And of course, that's going to be, I'm talking more to my experiences, and it's going to be different by area and province for sure. But many agencies are able to offer, you know, phone support or through video conferencing platforms like Zoom. I use Microsoft Teams. I found that really easy to use. I'm doing online therapy sessions with lots of my kiddos, the majority of the students I was seeing in classrooms. And as well, I have 2 therapeutic assistants for speech and language that are also continuing to see kids that they were seeing before school closures. So really, it's going to be important to just have a discussion with your SLP that is supporting you about what kind of support options are available. So whether that is phone check-ins, teletherapy or telehealth sessions, or maybe providing some online materials, you know, sending them on to parents through Google Classrooms or through email. Those are all possible options that you may want to investigate. Next slide, please. So many SLPs, I know my team and myself have worked really hard to adapt a lot of the screening and therapy materials that we were using in person to make it into an online format. So it's easy to use during telepractice sessions to support mainly, like I said, I work with kids and their families. So, you know, we were still in the midst of screening to find kiddos that were appropriate for our programs in the fall. And So of course that looks very different. We're used to being in person, but you know, I made observations during video sessions with families and just asked them to support me and have materials ready. And also they were able to videotape their kiddos playing, again, with some background, you know, have these different toys available, you know, books and Lego and things they like to play with, and just guiding them so that I had enough information to kind of go to next steps and what needed to be done and which kind of services and strategies would be appropriate. We've made interactive Google and PowerPoint slides to engage younger kiddos. It's, you know, it's a little bit easier when you're in person and you have all your fun games in front of you to keep kiddos engaged. And even in preschool and kindergarten age, oftentimes the attention span isn't that long. So it's important to have materials that are going to keep kiddos engaged. And certainly we've found some ways to do that. I have been making customized video examples. So if parents aren't able to meet me for specific Zoom or Microsoft Teams sessions at a specific time due to work or you know, family life, then I make a video and it's just basically like I'm in person, I'm modeling the speech sounds for them, I'm talking about strategies, and I'm giving the kiddo time to respond to me while I'm making the video. So it's something that the families can use over and over. And the kiddos like to see my face and know that, you know, Miss Tracy's here and it's time for speech practice. So I think that's been very helpful. Next slide, please. And again, I just want to clarify that, you know, many of the supports that we were able to provide in person are still available through Telepractice. So those parents that had concerns about speech clarity, I'm still able to see how they're doing with their speech sound progress and determine which areas do we still need to work on through some online screening and informal assessments, you know, listening and informal ways of just figuring out what do we need to do next. I can support the speech sound listening practice, discrimination practice, and production practice all through this online format. And we're still supporting clients and families who at the time were trialing new AAC systems. So I had a girl in grade 5 who was moving from a Prolo 2 system to a touch chat. And I have a little guy in kindergarten who is just kind of getting into a touch chat system. So we're still able to support those families moving forward and trying to get funding for a full-time system for them. Next slide, please. So really I found, you know, and lots of people are questioning, is this the same? Is this online format going to be an effective way to work on these sounds and maintain the progress and make gains compared to in-person services? And I can honestly say that I had my doubts. I am not going to lie. It was quite daunting getting started, but I've seen lots of benefits and lots of growth. I mean, I get to see lots of parents far more than I would have in the school context. You reduce travel time, so you don't have to worry about, oh, it takes me 30 minutes to get there. I have far more time to actually work with clients. Again, building that capacity with family and caregivers, that's huge. So it's not just me working on skills independently with the children, it is me teaching family and caregivers how to do the same thing every day, which makes a huge impact. And materials and videos can be used and viewed many times for repeated practice. I think it just supports families knowing that, you know what, I can do this too. You know, I see her doing it on the video, that's not hard. I can read the book in the same way, or I can practice sounds in the same way too. Next slide, please. And just to reiterate, I mean, we've worked really hard. There's lots of, I'm on a Facebook group where there's lots of SLPs who have been working really hard and talking about different ways to keep kiddos engaged and kind of building this community of making telepractice better. And since we do know, we keep hearing what is going to be normal. Are we going to return to classes in September? We don't know. And so we're trying to think of different ways to provide screening and assessment and consultation and treatment. And I do know assessment is one of those things that's very difficult to do because you're changing the way that you're administering formal. But I know there's one company who does make a lot of SLP tests, Pearson, and they have developed online formatting, not that we can present it in this format yet, but if we could get together and even, you know, behind a screen or something, they're working on ways that we can use 2 iPads to complete the same testing, which would be a really great option. If you currently aren't receiving supports from an SLP, but you're interested in receiving supports, I just wanted to mention a few options. Public schools, Catholic schools, private schools, charter schools often are associated with an SLP. So talk to the school admin and see what are options for you. Your local community and health authorities, so your local health centers, give them a call and see what options are available for both pediatrics and adults. Specialized service providers like Family Support for Children with Disabilities, or FSCD, are still providing online formatting as well. I have clients who are still accessing those services, and there's always private practice providers in each area, and there is a private practice website, www.asapp.ca, where you can go by area and see providers in your area, and they list the specific concerns they will address for you. And then, so that's just somewhere I got some of my information and some helpful tips and information sheets if anybody was interested in having a look. Thank you so much.
Thank you so much, Tracy. So now is a time for questions. I see that there are 2 questions already in the Q&A box. Maybe we can start with the one from Jill. Is chewing the sides of your mouth at night and while you're eating helped by derma fillers? Dr. Ball, can you speak to this?
Actually, I can't. I'm sorry, I don't know the answer to that.
Yeah, KIERA or Tracy, any information on this topic about derma fillers and chewing?
I have not, this is KIERA, I have not tried that. So I don't know a ton about that. Usually I will encourage people to maybe slow down a little bit. I worry that if people are biting their cheeks while eating or something, that it's due to sort of low tone in those cheek muscles, but I don't know about at night for sure. So sorry, I don't have a great answer either though.
No, thank you both. This is from Alicia. I have a question about voice. I have myasthenia gravis and get dysphonia. I'm a singer and now my voice goes out easily. I had voice therapy prior to the diagnosis for muscle tension dysphonia and nodules. Will the exercises I learned for that help or hurt my voice now that I have myasthenia gravis? KIERA, Tracy, or Dr. Ball?
This is KIERA again. Myasthenia gravis is one of the diseases that we really don't know a ton about for exercise, and it's the one where we really don't want to fatigue people very quickly with. So I would be a little bit cautious about it. I'm not sure if you, Alicia, had the voice issue at the same, or was doing the voice therapy and singing and all of that with the myasthenia gravis, or whether those happened at 2 different points in your life. And so I would caution that, but there is some newer literature coming out, at least for limb, that maybe mild exercise in MG is tolerated. So stay tuned.
Right, and this is Dr. Ball. I would agree. I think you know, certainly I wouldn't try to do it to the point of fatigue. And a lot of times, yeah, so I would just use caution as well.
Excellent. How do you help someone in a power chair who is choking? Do you recommend using the device called LifeVac? Anyone familiar with that device?
This is KIERA again. I haven't seen the LifeVac. Usually the respiratory therapists that I work with in the multidisciplinary clinics would actually encourage the use of the Heimlich. Even for people in a chair, you can do it in a modified form. And so I would touch base with a pulmonologist or respiratory therapist.
Great. Are there any mouth stretches and exercise that can be done with boys with Duchenne muscular dystrophy? And what I can also do is I'm taking a note of all the questions, and we have an account here at Muscular Dystrophy Canada called research@muscle.ca. We can provide more information based on the literature and reaching out to experts like our panelists. There were some questions that were sent in, so I just want to quickly go through those as well. This individual has myotonic muscular dystrophy and would like to know if their speech pattern or swallowing may be affected as their muscular dystrophy progresses. Do we have any information on aging with a muscular dystrophy and whether that affects speech over time?
This is KIERA again. We are in the middle of a longitudinal study with congenital myotonic dystrophy, and we definitely do see changes there. We are gearing up to do look at this a little more closely with adults as well too. I would say anecdotally from clinic that yes, that is something that changes over time and unfortunately gets a little bit worse over time for both speech and swallow.
Excellent. As a family member, is there anything that we can do to help with choking? That's been a question in the Q&A.
I would actually refer back to kind of the slides, and I think you'll make those the webinar available online. Is that correct?
That's correct. Yes.
Yeah. So there's recommendations in there. It might be quicker that way.
Perfect. Great. This one has been addressed, but just to revisit it, it's a common question. So children are seeing their SLP very frequently as part of a pediatric neuromuscular clinic, but once they graduate, so to speak, and go to an adult clinic, they see their neurologist. But is it common for adults with SMA to be seen routinely by an SLP, or is that recommended?
So I can, this is Dr. Ball, I can reply to that. And my experience, it's interesting because I was working in a very large urban children's hospital, and we ran into this often because as children would age out, we would refer them to an adult neurologist. And typically the adult neurologist did not work with an SLP, but what we found was we actually created a program to make sure that they were transitioning to the personnel that they needed to be followed with. And typically children with SMA do transition and benefit from seeing a speech pathologist regularly as well. And so I would recommend that you try to seek someone that is familiar with SMA, and perhaps it's possible, I don't know the Canadian system well, but it may be possible to even be followed by the same SLP potentially.
Great. Excellent. This one was answered by KIERA already in her slide, so I'm going to go ahead and pass on it. Is hearing loss common for certain neuromuscular disorders? What I'm also going to do is just go ahead and put up this slide, which is our research at Muscle Dossier. If we didn't get to your question, or if this webinar makes you think of other questions related to speech, swallowing, and communication for neuromuscular disorders, please go ahead and email or give us a call. To end today's webinar, I would like to thank our speakers for sharing their insights, and to our mission team at Muscular Dystrophy Canada for their ongoing work with supporting individuals in our neuromuscular community. I will post top 5 key learnings from this webinar by the end of today. And as I mentioned, the video recording of this webinar will be made available on our YouTube channel. Thank you all so much. Have a great rest of your day.